2 million people hooked on opioids.
It snowballed quickly from the oxys to whatever pills she could get her hands on, to a friend introducing her to heroin.
It's being called a death trap. At least 130 overdose nationwide every day, 17 right here in Florida.
We were seeing morgues that couldn't handle the total bodies that were coming in as a result of overdose deaths.
Addiction. Destroying lives, tearing apart families.
It doesn't matter your socioeconomic status. It doesn't matter what your job is. It leaves a huge void. It's a crater.
Now, the search for answers.
I would say it is the #1 pressing issue in terms of health of American citizens.
And the demands for action.
I don't think that this is a problem we'll ever be able to spend our way out of.
This is Town Hall, Addicted Florida.
Good evening, and thank you for joining us. When you hear those numbers, they are startling. But one of the things we want to be very mindful of tonight as we go through this discussion on the opioid crisis is that behind every one of those numbers, there is a human being. There's a face. There's a mother. There's a father. There's someone's child. Real human beings. The impact is far-reaching. It is beyond the person who's addicted. It is an impact on the family. It's an impact on society, the criminal justice system, jails overcrowded, the social welfare systems, the child welfare system, all of them overburdened because of this crisis. Tonight, we're going to take the opportunity with a distinguished panel, with an audience who's here, and through each of you, you'll have an opportunity to weigh in as well, to look at the opioid crisis and how it impacts each and every one of us, how it impacts our communities, and hopefully more importantly, what we can do about it, how we can start on that road to solutions. Channel 3's Corus Nylander sat down with Florida Attorney General Ashley Moody very recently. We want to listen now and get her perspective on where we stand.
The numbers are staggering. 17 lives lost every 24 hours. That's how many people die a day in Florida from prescription and illegal painkillers called opioids. According to Attorney General Ashley Moody's office, Pensacola and Panama City are among the top 15 cities in the nation for opioid overdoses. The crisis, costly for the state of Florida. According to new research, Florida spends nearly $32 billion a year on overdoses. I went to Tallahassee, into Moody's office at the Capitol building to learn more about what's being done to change the disturbing statistics.
It is the #1 health issue we're facing, not only in Florida, but nationwide.
Moody is leading a statewide task force created by Governor Ron DeSantis via an executive order to try and get a handle on the issue.
We have a 21-member body that is looking at the state to determine what's being done, what's worked, what has not worked, what we can recommend to counties that need some help in recovering.
Right now, the group has yet to have any major breakthroughs. The group, relatively new, the numbers, particularly in Northwest Florida, still growing.
I know Escambia County is still seeing an increase in deaths. So this is not a problem that is going to be solved overnight.
Is there blame to be had on the pharmaceutical companies?
Absolutely, absolutely. And, you know, we are, within the Attorney General's office, aggressively pursuing action against manufacturers, distributors, and pharmacies that we believe led to this man-made crisis.
The state is suing several big pharma companies. Moody hopes whatever money is recovered from that will go right back into fighting the crisis. But she says this is going to take more than money and goes beyond just holding people accountable.
I don't want people to think that this in any way is behind us. It is not. We are in this fight every day, not only in the court of law, but in public awareness and in trying to save those that are addicted to these painkillers and illicit drugs. So you being here and conducting an interview and making sure that the Panhandle stays aware is vitally important to us being able to make a difference.
In Tallahassee, I'm Corus Nylander reporting.
And now our discussion begins, and helping us to facilitate that, we're delighted to have and honored to be a part of the WSRE team tonight, and them joining us in this effort. We have Jeff Weeks from WSRE, and he will be facilitating comments and questions from our audience.
Sue, thank you very much. And you know, this is an issue that has affected so many across the nation. You might hear about it on the news, perhaps read about it in the paper or in a magazine, but do you know what's going on in your neighborhood? Do you know how it's really affecting your community? Well, tonight we've assembled some audience members who unfortunately have had to find out the hard way. You're going to hear some of their personal stories, some of their intimate stories. We're also going to talk with members of law enforcement and the state attorney's office and find out what they're doing to make Florida a better place and fight the opioid epidemic. Sue?
Also, as part of our initiative tonight, I am delighted to say we have with us my colleague, April Baker. She will be entertaining your questions through social media. She will be your voice.
Sue, thank you so much. I know that many of you can't be here today, so that's okay. You can send us your questions. Many of you have pressing questions that you want answered, so you can send them to us. We are tracking our Facebook and Twitter pages as we speak. We're monitoring them, and we are gladly pulling them out of our feed and presenting them to our distinguished panelists as soon as they come in. And to ensure that we see your question as soon as possible, we are encouraging you to use two hashtags, hashtag opioid crisis and hashtag your voice, your future. And also don't forget to tag WEAR TV with those questions. That will allow us to see them quickly and allow them to answer them as soon as possible. So again, send in your questions. We'd love to hear from you. I know many people are personally affected, many people at our station as well, many of you in the audience, and we thank you for being here. So, Sue.
And now our panelist, Dennis Dawson. He is the resident agent in charge for the Pensacola office of the Drug Enforcement Administration. Jeff Gaddy, an associate attorney with the Levin Papantonio law firm and also a former assistant state attorney. We have with us Dr. Paul Glisson. He is Vice President of Medical Affairs for Baptist Healthcare and also an emergency room physician. And we have Dustin Perry, a licensed clinical social worker and Director of Medication-Assisted Treatment Services at Lakeview Center. And panelists, certainly we thank you for being here this evening. I would like to give each of you an opportunity from your various areas of expertise to tell us where you see the opioid crisis in our communities and perhaps in society as a whole. What are we facing?
Here in our area, obviously our heroin seizures and opioid seizures are on the rise. With that being said, we've taken initiatives throughout DEA to create groups that come and help us with the different type of investigation, especially something centered around an overdose or something to that effect. But besides that, here in Pensacola, we're committed to targeting the worst of these groups here in this area to work it back to our source cities to cut off the source of supply for these drugs coming into our area.
Jeff?
So my law firm, Levin Papantonio, has the honor of representing over 650 local governments in litigation against the pharmaceutical manufacturers and distributors of opioids for their role in causing this crisis that is so adversely impacting so many of our communities. We've spent the last 3 years not only traveling the country and visiting with many local communities and seeing the devastating impact of opioids on the people within those communities, but also investigating the manufacturers of these pills and the distributors of these pills and ferreting out their conduct that led to this crisis, whether it was the manufacturers falsely pushing the narrative that these pills were not addictive and were appropriate to be prescribed for long-term use, or whether it was the distributors who had a role to be the beat cops and be on the lookout for pills getting into areas where they shouldn't, and they failed abysmally at that job. So from our perspective, we've seen that not just here in Florida, but on a national basis, and we've been pursuing that for some time now.
Dr. Glisson, from a healthcare perspective.
Well, Sue, in my position, I sit both as a practicing emergency medicine physician as well as an administration where I'm responsible for giving feedback to state governments here in Florida, as well as designing, implementing, and being the driving force behind a lot of the policies that are coming now from Tallahassee. And I will say where I see us right now is we're at an awakening. And I want to thank WSRE and WEAR3 for putting this together, because this part of the awakening is that we're admitting that there's a problem, and we're trying to get rid of the stigma that goes around with being an addict, because that's not where we want to be. That's from 1980s, 1990s, and now we want to say that this is a medically recognized condition, and we want to treat that as a multifaceted approach from that. And so this is the first step of that. So thank you so much for putting this together and having this panel here with us.
And Dustin Perry, that really dovetails right into you and your area of expertise.
It really does. So Lakeview Center is trying to provide a variety of treatments, whether it's abstinence-based, medication-assisted treatment, inpatient, outpatient. We're really trying to affect as many lives as we can, and not the individual. The individual is important to us, but we really want to impact the community. This isn't an individual problem. It's a family problem, it's a community problem, it's a state problem and a national problem. So we're very excited that we can be a part of that.
Is it a situation where if we don't look at how we got here, we don't know how we get out of here? And going on that premise, how did we get here? There are those who would say that you're talking about Big Pharma, not realizing or not admitting that we had a drug that was very addictive. Are we talking about physicians overprescribing, not being cognizant of the fact that you've got a patient who's coming back time and time again? It's and not a matter of a blame game, but how did we get here?
So from our perspective, it's fairly simple. Opioids are not new. They've been around for centuries, back to the Byzantine days or the opium wars. It's always been known within the doctor and the medical community that these drugs are dangerous. And what happened was in the 1990s, the manufacturers of opioids, the drug companies, the big pharma companies that made these pills, came to the conclusion that if they could convince the doctor and the patient community that it was okay to prescribe these pills for chronic pain, that means long-term, more than 10 days, talking 30 or 60-day prescriptions, that they could greatly increase their bottom line. And as we know from the situation that we're in now, those efforts were very successful. When you couple that with the actions of the distributors who were supposed to be on the lookout for increased shipments, whether it was quantity or quality or the pattern, and they turned a blind eye to the pills that were flooding our communities, that's where we got to where we are now.
Dr. Glisson?
I think physicians have a large part to play in that as well. And being a physician for myself, I'm sure a lot of physicians hearing me say that are cringing as I say that. So, but I do think we number one, accepted some kind of shady research back in the 90s. And a physician himself who from the American Pain Society, Dr. Campbell, is the one that started the whole process of saying that pain is the fifth vital sign. And we could talk for several hours about what that chain of events that happened, how that fifth vital sign became now something that was measurable by CMS. It was then measured and quantized by the Joint Commission, and that tied into accreditation for hospitals and for you to have your license. And it still flows into the patient experience scores, which are measured now by HCAHPS. And if you don't give patients, make them happy about their pain medications here, that factors into HCAHPS scores, which directly feeds into value-based purchasing, so it affects the bottom line for Medicare reimbursement for hospitals and stuff now. So we're still in an area where physicians may not want to be influenced by the things that are going on in society, but we are. And pharma, they've had duplicitous behavior about this, and they really have been taking advantage of the poor research and then paying physicians inappropriately and having shady marketing. I'm sure that's what your firm there has found there, that they really have crossed the line as far as influencing on physicians.
For those of us who are consumers, and if you've been into an ER or any of the hospital rooms, you see the little smiley face emojis, and what is your level of pain? Have we as a society, we as individuals gotten to a place, we don't want to hurt at all. We don't want any level of discomfort. So the expectation is, and if I have a physician who isn't getting me out of the pain and getting me out of the pain immediately, then I'm going to go somewhere else. I'm going to look around until I get that.
Correct. Yeah, and it is still considered a fifth vital sign in many areas there, so it must be addressed. And it's kind of ridiculous that we look at your pain scale, which is very subjective, and that's from the 1980s because it came out of nursing journals that really said that pain is what a patient says it is. And I think as providers in the room, they were talking about this, we know that pain is very subjective, and just saying that you have a pain scale of 4 does not mean I need to give you 2 milligrams of morphine. But that's what it's evolved from pain is what you say it is to pain treatment is what you say it is. And I think physicians have been saying that for some time now, and that's why I'm excited that we're having this awakening here, this open discussion about this where we can talk about it without the stigma that goes along with it.
Jeff?
I'd be curious to address this to Mr. Gaddy. I've read some research along the way and some articles that have been rather astounding at some of the efforts that the drug companies put into marketing to the doctors to convince them that this was okay. I know your firm is doing a lot of discovery on that. Can you elaborate on that a bit?
Absolutely. It dovetails with what I said a moment ago, that back in the early 90s, some of these companies led by Purdue Pharma, which I'm sure most people are familiar with, determined that if they could convince the doctor and patient community that these drugs were safe, they could greatly increase their bottom line. They set about with several different ways to do that. One involved seeing doctors directly. They went into the offices of doctors who didn't typically deal with pain management, whether it was family practitioners, dentists, orthopedic surgeons, and they started selling them on the concept that these drugs were safe for long-term use. It had to do with paying doctors, which Dr. Glisson alluded to a minute ago, to go on a speaking tour around the continuing medical education conferences and talk on the benefits of these drugs, the purported benefits, I should say, and leave out the risks. So all of those methods were utilized by Big Pharma. All of them were largely successful and led to where we are today.
And Dennis, I want to ask you, when you mentioned that you're going after the worst of the worst, you are trying to get to the source and stop that supply coming in. Is there a fine line that you walk in law enforcement, and perhaps some of those in our audience in law enforcement might be able to address this as well? When you see someone who is addicted and they have now fallen into the criminal realm, if you would, where do we draw the line with, okay, let's just lock them up versus, get that person to treatment and help?
The DEA, we're targeting the sources that are bringing these drugs into our area and taking advantage of those people. So that's what we work hard to, is to look at the people in our area who are bringing the drugs in here, whether it be from Mexico or China, or having their own pill press to put these out in the community. So that's what we're really focused on, is getting the source so that we can chop the head of the snake off before we get to the tail. That's pretty much where we try to focus our efforts, and we work with our local partners to build on those cases that they have, and then deal with the addicted people on a different level.
If we don't reach that person who is addicted and deal with them at whatever level they are, Dustin, I would imagine we start to see that cycle. That cycle that just continues and it spins. And at some point, do we run out of money? We turn to that life of crime. We're going to do whatever it takes to get those drugs. So where does the intersection come?
Well, I think it is a very fine line. It's very easy to say, I'm buying prescriptions and then selling a few to cover my use versus the person that's bringing it in and causing harm to the community. And I don't envy law enforcement for having to make that decision between who is the addict and who's the dealer, because it's a very tricky place to be, and I would err on the side of providing treatment if there's that question. If you question, is it time for treatment or is it time for arrest, I would lean towards treatment first, because we can always arrest later.
All right, Jeff?
Jeff Tharp is with the U.S. Attorney's Office. One of the things that we were talking about prior to going on the air is you said something that sort of intrigued me. You said, we can't prosecute our way out of this. What is your office doing to try to dampen this opioid epidemic?
Yes, prosecution, the enforcement is what everyone thinks about when you think about the U.S. Attorney's Office and the Department of Justice. But we realized a few years ago with this epidemic that we had to go, besides our prosecutions, which we do, we also have a prevention and outreach program. This program, we try to target preventing people from using opioids to begin with, and usually that is in pill form or prescription form. And the way we do that, we have a program called Chasing the Dragon, which is targeted towards college-age students. And we go to universities. So we've done one here a few years ago at University of West Florida. We've gone had the program at Florida State University, and also many other colleges throughout our district, which runs from here to Gainesville.
Where do you draw the line of the folks you do prosecute?
Well, like what Dennis said, with Special Agent Dawson, the U.S. Attorney's Office and the federal government, we're going after the worst of the worst. So when we look at these cases, they're wide-ranging investigations, but we work very closely with our federal partners like the DEA and the FBI and Homeland Security investigations, but also with all these law enforcement officers you see here today. We have investigations right now, and we have prosecutions all through Northwest Florida, from Escambia County all the way over to Walton County, and really all through the district, all the way to Gainesville. But these investigations and prosecutions are wide-ranging. We go after doctors that are illegally prescribing pills to patients or really addicts. We've got after doctors. We've prosecuted nurses for stealing opioids from the hospital. We've prosecuted doctors for illegally writing scripts for family members and themselves. And we also go after, like Dennis said, the drug trafficking organizations. So the actual individuals and organized crime that are bringing kilos of fentanyl, kilos of heroin into our communities. And those are coming from out of state, and with our federal resources and our state partners and our local partners, we try to go after those criminals. And then also we do go after, and I think you've seen some in the news recently with our gun initiative here and also in Tallahassee, we're going after the violent offenders that are the street dealers. So when guns are involved, and we go after the individuals that are selling to the end user, which are the addicts. So we have a wide range of targets, but our goal is to go after the worst of the worst, and those are the ones that are selling the drugs or bringing the drugs into our community.
I'm curious to know, Mr. Gaddy's firm is going after many of the companies who did this, kind of got this rolling along, but that's a civil situation, right? Might there be any criminal action?
And that is something that in our district, that is something that's probably, if it's going to happen or that decision is going to be made, that would be in Washington, D.C. And our district, what we're focused on here is a prosecution of the people that affect our community, that we target those individuals, those criminals, and also the prevention of college-age kids and other people from preventing to use opioids in the first place.
Mr. Gaddy, let me just get you to follow up on that. Any possibility that this would be some sort of criminal charge at the executive level?
So I appreciate you asking that question, Jeff. One of the things that I think is important to point out is that the delivery mechanism, that is how opioids come into our country and ultimately get to the patient, it is complicated. And there's a lot of different steps in that process. And we talked about doctors earlier, and are there situations where there are doctors who probably didn't live up to their expectations and maybe wrote too many scripts? Sure, there were. Were there pill mills where there were pharmacists that were just filling any script that walked through the door? Yes, that happened too. Are there drug dealers on the corner who are targeting our children? Yes, there are. But the DEA and local law enforcement has gone after the doctors, and they've targeted them, and they've identified the ones that should be prosecuted, and they've arrested them, and they put them in jail. They've done the same thing with the pill mills. They've closed them down. The drug dealers on the street, they've gone after them, put them in handcuffs, and taken them to jail. Nobody's done that with Big Pharma. And the reason is that Big Pharma looks different than the kid on the corner selling drugs. That's why nobody's gone after Big Pharma, and we hope with the information that we've uncovered in the documents that we've reviewed and the depositions that we've taken, that when we're able to make all of this public, that we can see some of that happen and see people actually held accountable for the damage that they've done in all of our communities.
I'm curious with your work, are you optimistic right now, or do you feel like you're fighting an uphill battle?
I think with all of our law enforcement partners you see here today, and we work really well together, and we're doing what we can on the law enforcement side of it, and some prevention, but on the law enforcement side to try to target the drug trafficking organizations and the worst of the worst in this community. But it's going to take a community effort with the prevention folks and the recovery with Lakeview, which we use a lot. Once someone gets convicted in federal court and they get out of prison, they're on supervised release, and the U.S. court system with probation uses Lakeview to try to get individuals that are addicts. There's in the Bureau of Prisons, they have programs, and also when they're released, there are federally funded programs, and through Lakeview is one of them, to try to rehab and get people jobs and the education they need to hopefully get off opioids.
When we talk about the situation, as we have talked about the criminal element, if you would, sometimes it's helpful for us to be reminded of those victims and who and what they are, what they look like. And they come from families just like yours and mine. We recently had the opportunity to sit down with a mother who has a story to share. And she very freely shared that with us. And it's the story of how her child was ensnared by this opioid crisis. Channel 3's Rebecca Castor shares her story.
Gigi Velarde was only 24 years old when she died. It's a tragic story of addiction that can affect even the most loving of homes. Leslie and her husband adopted Gigi at birth.
She was always a challenging child. From the time she was about 5 and started at MB Cook, she was challenging. She just had a wild spirit, and looking back on it, I see that better and wish I had done it better.
Leslie says her daughter's interest in drugs began at an early age.
I know that she dabbled in drugs probably since she was about 13. So I knew that, and we had many discussions and problems with it. From the addict's mouth, which is her mouth, she said that after she had our grandson, Jonah, she was prescribed opioids, and during her recovery, which was a C-section birth, she became hooked.
And the addiction only got worse.
It snowballed quickly from the oxys to whatever pills she could get her hands on, to a friend introducing her to heroin.
This lasted several years, with Gigi in and out of rehab, until tragedy struck the family on Leslie's grandson's 4th birthday.
We had made plans the night before to do special things for his birthday. And I started calling her at 7, and she wasn't here, and 8, and 9, and 10, and 11, 12, all day long. And I was afraid to drive by, because I knew I would see her car, and it would make me mad, because she was sleeping, right? She slept a lot. Then it got to be time to actually do real birthday stuff, birthday cake, and she wasn't here, so I got in my car. We went to her apartment and walked in and found her.
Now, only 9 months after her death, the family is adjusting to life without Gigi.
She was such a force, in and out of rehab, in and out of addiction, and in and out of, daily life, that it's empty. It's like living with a tornado, right? It's just constant swirl of chaos and drama, and when that's gone, it's very calming. I'll say that things are a lot calmer around here, but it leaves a huge void. It's a crater.
Leslie hopes that being honest about her daughter's death will show other parents that addiction can truly happen in any home.
It doesn't matter your socioeconomic status. It doesn't matter what your job is. Your child is going to be either predisposed for addiction or not. It's just, that's how I feel. And you just have to watch and make sure that you're going to do an early intervention.
Leslie says there are signs that point to addiction. Learn more on our website, WEARTV.com. Reporting in Pensacola, Rebecca Castor, Channel 3 News.
And Gigi's mom is here with us tonight.
Leslie, first of all, thank you. It takes a tremendous amount of courage to do what you're doing, so thank you. But I guess, why are you being so open?
First of all, thanks for having this town hall. I think it's really important. Why am I doing it? I'd like to see the marriage between the law enforcement, the mental health facilities, and the counselors do a better job of following up with kids. We ran out of resources, and so we couldn't send her to, rehabs in California and things like that. And I just didn't feel like there was enough follow-up from her rehab. Mm-hmm. So that's one thing I wanted to get out there, is see if there's some sort of a marriage that could be made between what's going on in the courts and being arrested and how that's beginning to work better. I feel like right now, it's the little boy with his finger in the dike. This is not just a crisis. it's an epidemic.
Yeah.
And that water's going to swirl, and it's going to overcome that dam. And not only now does it affect 1 in 7 people, it's soon going to start affecting 1 in 5, and soon 1 in 3 with the rate that we're going.
Have you talked to other parents who've had similar experience?
I unfortunately have. I've had, since my daughter died, 3 of her peers also die from opioid events. So yeah, I've talked to parents about it.
What's your advice to them?
My advice is, number one, and I think that the panel is addressing it really well, is if and when an opioid is prescribed, you as a parent and the person receiving it is just given more information about it. That it's not a drug to be played with, it is for a specific amount of time, and doesn't really need to be prescribed.
Yeah. At what point in this situation with your daughter did you realize we might have a problem?
When I found needles in her bedroom. Okay. I mean, that's the truth. You don't ever think in a million years that that beautiful little girl would be scarring her body that way. And when we found it, because we were in disbelief the whole time, we just couldn't believe it. And I think most parents are that way. So my goal is to get out there and say, believe it, watch it, find it, and intervene as soon as possible.
So to make the point, she went from taking an opioid, a pill that you might take for an orthopedic injury or something along those lines, to needles.
Yes. She went from having a pretty difficult pregnancy with my grandson and being prescribed opioids for her pain after the C-section, which was a very difficult recovery for her. And she went from there to buying things illegally.
And Leslie, I just wanted to take the opportunity as well to thank you for sharing your story. I think one of the things we hear is that so often parents and loved ones feel that they are on this journey alone, that they're swirling by themselves. So thank you so much for sharing your story tonight. Thanks. April, I believe you have some input from some of the individuals who are watching us via social media.
Yes, and Leslie, thank you so much for sharing your story. It's very touching, and I'm very sorry for your loss as well. We've seen some passionate responses on social media from people who feel like they're being treated like drug addicts, and there are concerns coming from people who actually need these pain pills, who need them to ease their pain and discomfort. So how do those not addicted to opioids get help from doctors and ease their pain? Is there a certain, it just seems like there's hurdles to overcome for them and struggles.
Dr. Glisson, perhaps you and Dustin can respond to that.
Well, first of all, I would say that every patient is an individual, and it's hard to give a generalized no one solution is going to meet every need for every patient. Some patients need medication assistance therapy, which Dustin and his team uses there at Lakeview. Others would benefit more from abstinence. But no matter what treatment plan you choose, it's going to be multifaceted. It's going to require the families to be involved in that. And I think that we've seen a lot of success from mutual aid societies too, such as AA and NA, because they bring the follow-up that you mentioned there that they don't have there. I think we've seen that those are just as successful as professionals because they really focus on the follow-up and closing the gap there. Dustin probably could tell you more specifics about what they offer here at Lakeview.
Yeah, and I think having that conversation in approaching your physician or your counselor and saying, I have this problem, and I'd like to talk about some personalized choices. It doesn't have to be that the doctor prescribes opioids. There's alternatives. You can get Tylenol, Motrin. Those are all medications that work for pain relief. It doesn't have to be an opioid. So having the conversation and saying, I've got this issue and I'd really like to get some help that isn't going to lead down this path that I hear so much about. The idea that it's not going to happen to you just isn't true. So many people that thought it wasn't going to happen to their parents are sitting in this room, unfortunately. Their loved ones are sitting in this room. I talk to them every day and they say, it wasn't going to happen to me. The doctor said it was okay, so I did it. I didn't ask any questions. The doctor just said, here's your month of Oxycontin, and we'll see you next month. And then if you came back in 3 weeks, the doc said, here's your month of Oxycontin, we'll see you back in a month. And when you came back in 2 weeks, they just continued that cycle because you weren't having that conversation. You weren't saying, doc, this is too much for me. I'm taking too much, or somebody's taking it from me. So have the conversation, open it up to have the conversation with a doctor or a counselor.
So I'll also mention too that There's been several new steps brought out from Tallahassee here in Florida here, the HB 451 recently, that requires now providers who provide narcotic or scheduled prescriptions for pain control to provide the patient at the time of prescription. A pamphlet here is called Alternatives to Opioids. So if you're getting new prescriptions now, and I have a copy of it here, but it's on their website here for the Florida Department of Health, as well as your provider obviously should be giving this to you as you get a prescription for it here. And it basically requires the provider now to have a conversation, just like Dustin was talking about there, about what the alternatives are to opioids. And it lists here obviously the simple things from Tylenol and Motrin to other things such as antidepressants, interventional pain management, non-opioid anesthesia, self-care, rehab therapy such as occupational and physical therapy, and the behavioral and mental health therapies, which I think are gaining a lot of prominence here for chronic pain control as well too. So this conversation should be happening at the time of prescribing here in Florida now, and I think that's, at the time when it came out, I didn't think we'd be able to do that. I didn't think it was a good idea. I was like, I don't have time for this conversation. But of course we have time for that conversation. We're here to take care of the patients, and that if it requires 3 hours to talk about this, we just have to do that. And I know, again, a lot of the physicians are cringing about that, and I have some emergency medicine friends in the audience here. We realize that every minute we have is critical to spend with patients, but this is probably a good minute or two well spent to talk about alternatives. Because I think so many times patients are just very apt to do what the provider says and take them at their word. So this will at least open that conversation for them.
Jeff, while you are going after things from a civil standpoint, are these some of the questions or some of the issues that you're also trying to address as you're going after Big Pharma and the others? Again, from a civil perspective, are you trying to see that they do put in place, that they have to advise, that they have to do this, that they have to do that?
Absolutely, and one of the points that April made was that there are folks that hear all this and say, oh, well I need these drugs. I think it's important to note that there's a big difference between taking opioids on a very short-term basis, for acute pain, surgical pain. Nobody's saying that's inappropriate. Opioids may be appropriate for people who are experiencing cancer pain, end-of-life care. Nobody is arguing that those are any inappropriate uses for opioids. But the science and the medical literature is pretty clear that there's really no proven benefits to taking opioids on a chronic, long-term basis. And what's very clear is the risks are enormous. So yes, we are seeking to put in place public policy options that can help shape the conversation and the practices of doctors and patients when it comes to dealing with these drugs that can be so devastating if they're not used correctly.
And we do have a story there, a veteran who wanted to share his story about he felt he needed his drugs. And the question becomes, has the pendulum swung too far the other way? Of course, Nylander sat down and spoke with him. Let's take a listen, and then we'll further address that issue.
Well, Escambia County is showing some of the highest level of opioid overdoses in the state. The national crisis has caused sweeping changes across the entire medical industry. Today, doctors are simply needing a heightened awareness as they try and balance their patients' pain with a deadly dependence on these drugs. Donald Hoden is an Army veteran suffering from terminal prostate cancer, leaving him in constant pain.
If there's a fire in the house, I couldn't get out.
He has long been prescribed opioids for the pain, but due to new guidelines from the VA in light of the national crisis, he's being tapered off the drugs.
Can't do the things that I know I can do.
His son Everett says the active man he once knew is now bedridden.
It really didn't hit home until probably about April when I came to the house one day and saw my father laid out on the couch in extreme, excruciating pain.
It's just one of many impacts of the epidemic.
I don't think there's any family in the United States that's not affected by it.
All of Dr. Joan Lemon's patients suffer from opioid addiction or dependence.
Depending on how long a patient has been dependent on opiates, the harder it may be for them to get off, and some people can never get off of opiates.
Through methadone, they try to break patients free of their potentially deadly addiction.
I have seen patients that get up, shower, dress, pack a lunch for work, and we find them dead by the front door because they shoot heroin before they go to work.
One of the backlashes, doctors now limited in treating people with true opioid needs. Rules to prevent abuse tying their hands when it comes to treating people with serious pain.
There is limitation on how many days worth of opiates a doctor can write, and that is 3 days worth, 7 days worth, and then you have to have a valid reason for giving somebody more than that.
Some doctors are even jailed for recklessly prescribing the drugs. State Attorney John Mulchad says it's important to keep doctors in check, but it's a double-edged sword.
It really becomes a thing that drives them to do anything to get that drug.
I'm Cor Snowlander reporting.
Double-edged sword, pendulum swinging too far.
So I think it goes back to what I was saying before the piece ran. I think that you have to understand that there are certain appropriate uses of opioids. Again, nobody's arguing that the gentleman who's suffering from cancer may need appropriate medication to treat that pain. It's when you have the high school student who gets their wisdom teeth out that's given 30 days of Oxycontin. It's when you have the young football player who blows their knee out and is given 60 days worth of Vicodin over a long period of time. That's the inappropriate use of these drugs that we're seeking to stop and seeking to hold the folks accountable who push that message that was an okay thing to do.
Dennis, is one of the offshoots of that when they perhaps cannot get the prescribed drugs, that then they turn to something else, that we see the uptick perhaps in heroin use or other illegal drugs?
Yes, and we focus, our focus with the doctors are, the 1% of the doctors that are overprescribing and turning a blind eye to the different things that we were mentioning here and becoming pill meals, and then also the effects of being shut off there, then they're out trying to get the other illegal drugs that we also work hard to identify who those people are to cut down those sources also.
All right, April?
This feeds into it as well. A woman named Lucretia, it's her personal anecdote. She says she broke her back a few years ago and she moved to Jacksonville from Ohio, and she hadn't had problems getting pain pills in Ohio or Jacksonville, but it was only when she moved to Pensacola that she said she really had trouble in Escambia County getting access to these opioids. So I'm not sure if it's a geographic thing or if it's just her personal experience. Is there something to that?
Is there anyone who can address that? Any ideas as to why there might be a difference?
There shouldn't be in the state, as they mentioned in the piece there, that there's a 3-day and a 7-day exemption for pain control. There are exemptions for for cancer pain as well as acute orthopedic pain from trauma. And so I think those issues should be addressed by those exemptions. But back pain is not an exemption, and that's where I think that's where we want to focus our efforts there. That chronic opioid use is not appropriate for that.
Jeff?
Before I get to Lieutenant Austin, let me ask, how long does it take for you to become addicted? How many days or how many doses of opioids do you have to have before it's addictive?
Dustin, can you address that?
I don't know that there's any number for any person. One individual may take one and absolutely love it and go for the second one immediately. Another one, it may take 5 to 7 days before they become dependent, and then I think there's a really important distinction between being dependent on an opiate and being addicted to an opiate. So being dependent on an opiate means that you're going to experience withdrawal symptoms when you stop taking it. And that could be cramps, sweats, difficulty sleeping, GI issues, a variety of things. The addict is one that when he stops taking it, all he can think about, it kind of replaces food and water. If I don't have this opiate, then I can't get out of bed in the morning. I can't take my kids to school. I can't change my kid's diaper. All the things that come with real responsibility, such as food or water, that are necessities to life. And it varies individually. It could be 10 days, it could be 2 months. So.
It's my understanding it changes the dopamine in your brain so much that it can take years for you to get away from that desire of needing it. Is that correct?
Correct, absolutely. So the brain imaging that's happened in the last few decades has really shown that in a couple of days off of the substance, the brain starts to repair, but it can take 2 to 3 years for it to get mostly back to where it was. And there's no evidence to show that it fully repairs.
I think what's really scary about what Dustin said is there's no test for that. You can't go in and see your doctor and get blood drawn or have him do any diagnostic test and tell you whether you're a 1-pill person or a 10-day person. And so everybody goes in not knowing whether or not they're the person that's become addicted after a day or two of taking these drugs. And that's what makes it such a scary proposition, that these were being pushed on the community the way they were.
Sue was talking a couple of minutes ago about how you go basically from a legal drug that's been prescribed to all of a sudden someone is on heroin. Talking to you a few minutes ago, and you said that that's becoming a real problem in our area. Lieutenant Dawson is with the Pensacola Police Department. Expand on that.
I've been working narcotics over 20 years. In the 90s, 2000s, it was all pills. That's what we'd encounter in search warrants on the street. Street level sales would be pills. We are not really seeing that anymore. Pills are very hard to come by. Now it's all moved to heroin, it's all moved to fentanyl, which are deadly. In the past, we would see overdose deaths, but nowhere near to the scale that we're seeing it now with unregulated heroin and fentanyl.
When you hear the term black tar heroin, what is that?
It's just another concentrated form of heroin. We're not encountering, Agent Dawson can correct me, but most of it that we're encountering here in Pensacola is powder form.
So essentially, it almost seems hard to rationalize. I was prescribed a pill for my knee or whatever, and the next thing you know, you're on heroin. But you're seeing that rather quite a bit, is what you're telling me.
We are, and this is my opinion, doing this my entire life, is that some people have a very addicted personality. And whether it's heroin or methamphetamine or cocaine or anything, they're going to use those drugs. So while, addiction after surgery is an issue, and it has been an issue, in my experience, most addicts are cross-drug users. They'll use what they can get. They might have a preference as to what they prefer, but some people just have an addicted personality. If it wasn't heroin, if it's not pills, they'll go to heroin. If heroin's not available, they're going to go to whatever they can get. So I think that's really the societal problem that we're looking at.
Since we've seen an uptick in the opioid situation, how has the Pensacola Police Department changed their way of dealing with the narcotics on the street?
Well, there are safety issues. We've had fentanyl exposures with officers, so now there's a whole nother level of safety that we have to use when we encounter powders. So besides safety precautions, there's enforcement precautions that we need to do, different enforcement techniques. We rely on our partners with the DEA and Justice Department. So the name of the game is pretty much the same as it's always been. Techniques change over time, though.
We've seen the publicity on this epidemic rise, shall we say, in the past year or so. Have you seen any changes on the streets?
We do. In the past, you would have a sea of addicts on pills, but pharmaceuticals, and once again, I'm not saying they're safe, but we didn't experience the deaths like we are now. I think now that the pills are harder to get, they're harder to be prescribed large amounts, now people are making the move to heroin, and now we're starting to see a lot of overdose deaths, and I think that's really starting to affect the way that people see addiction now.
I'd like for us to look a little bit now into the broader aspects of this crisis, this epidemic, if you would. We have talked a lot, and we're hearing a lot about the impact on the addict. We've talked a bit about the criminal justice system and the impacts there. What about families? What about the disruptions that we are seeing? And I think these are some of the things that you have even addressed as you have pursued these lawsuits, that there is a price that the community pays for that, that somebody is bearing that cost and perhaps needs to be addressed. One of the things, for example, let's look at the foster care system, the child welfare system. We have right now a crisis of another proportion in the number of children who are entering that system. And it used to be over the many years that I have focused on that, it was typically your older children that we were seeing in foster care. Now the increase, it's 0 to 5. And we don't have enough foster homes. These children are being placed in homes where they're having to double up, because again, there are far too few homes, but the people who are willing to open their hearts and homes, they'll do it and they'll take one more, A lot of the children are being sent out of the area. Children who, maybe in kindergarten, first grade, all of a sudden you've been removed from your home and now you're having to be sent to Tallahassee, Jacksonville, even Miami, wherever there is a bed. This is another price that society is paying. There's a cost for that, And what is it doing to these children? And who's addressing that part of it?
This problem it's an octopus, and the tentacles are long. And we're seeing impacts from this crisis in so many different areas, whether it's law enforcement, whether it's community health centers, whether it's addiction recovery, and you're right that the most heartbreaking is when we see it impacting our children. And we're seeing it not just here locally, but all across the country, where you're having these systems that are just so incredibly strained because you have these parents that end up in situations where they're addicted and they can't care for the children themselves. You have grandparents trying to raise children all across the country who thought that they were out of the raising children business and have been forced back into it because there's no other solution. And we've seen that all across the country, and it's something that we're trying to address and bring in funding for so that we can address it in the proper way.
Dennis, from your perspective, when you go and when you're taking down the bad guy, if you would, and we have the images that we can conjure up on that, but I would imagine sometimes you're going into homes, you're going into places. What are you seeing? Because it's not just that person that you're apprehending.
Exactly. It's a very heartbreaking. Just the other day, we were working with some of our partners in our area, and we're entering a residence, and we're securing our house, and then there's a 2-year-old girl running in between police officers, crying and just hysterical, and we have to take time to rush in and grab these kids and bring them out of that chaos, to get them to a safe place. And then when we go into these houses and we're doing our collection of evidence, and you see where they're doing their drug deals and drug preparations on the kitchen counters, that places all these kids in the middle of that. That's the real heartbreaking part for us, and those are the things that really hit home with us, and that's why we work very hard at what we do. I know we keep talking about, hey, we're going after the worst of the worst, but that's what we're about and all of our partners, and that's why we have our task force here to really make a difference on the bigger level and also focus with community outreach stuff.
A couple of questions. When we look at the healthcare, the aspects of that and the impact on the healthcare system, what is the cost? When the individuals come in and they have overdose, when you're dealing with whatever the crisis might be that has been precipitated by the opioid use, are they insured? Is there compensation? Is this, uncompensated care that you're having to provide? Is it an extra burden? And from there, I want to look at another aspect of something. Back in the day, we remember the fetal alcohol syndrome when that was a crisis. The crack babies that we talked about for so many years. What is the impact on unborn children for a mother who is chemically exposed?
We still see a fair amount of that at our labor and delivery department here. When babies are born addicted already, it's heartbreaking, number one, and it's an emotional and physical strain on the nursing staff taking care of those babies. It's really unbelievable. You have to see this to really understand how heartbreaking it can be. The babies are very hard to console. Obviously, a newborn has to be held and fed and those type of things isn't normal. But we find that they are hyperstimulated and they have to be held almost 24 hours a day, 7 days a week. And it's hard to console them when they're born this way. And they have to stay, there's a protocol there to wean them off of that, and it takes sometimes weeks. And it's almost like we have to send our nursing staff home for a vacation after that. They need a break because they've been at it for so long, and just the emotional terror of it, watching the families having to deal with it too. So that is still a problem. And the baby stays for weeks in the hospital. The mom's already gone home, so the family is usually involved with Child Protective Services, and so it won't be returning home. It's an emotional burden that's for everyone, the caregivers as well as the staff there. So, and we also still have a big problem in our inpatient facilities for patients who are IV drug abusers who have been using heroin, and now maybe they have a spinal infection or something where they need long-term antibiotics. So they're going to have a IV intervention line place where they get IV antibiotics every day. But now that patient can't be released home because they would have an open access port to just inject the black tar heroin you talked about there straight into a vein. So those patients end up having to stay hospitalized for 6 weeks, 10 weeks sometimes to get therapy. And of course, the infection came from them shooting up using dirty needles and that kind of thing. So the toll there it's really immense in our healthcare system.
Dustin, do we have any idea yet? Are there any studies? Is there anything that tells us the long-term consequences, especially when we're dealing with infants who are born chemically exposed and they're born hooked? And even though they weaned off at whatever point, what is the long-term consequence? Do we know?
So I can't speak to the long-term consequences of illicit substance use. I know that we have very positive success when individuals are taking buprenorphine or methadone while pregnant. And if we can intervene early in the pregnancy and get them stable, they don't experience the withdrawal symptoms that may result in miscarriages. So we can get them to delivery. And then the neonatal abstinence syndrome that's post-delivery is actually reduced while they're on those medications. They're safe to take while breastfeeding. They're safe to take. And the success rates, it's not weeks typically, it's days. And as much as we've talked about the negative impact of the opiate crisis on child welfare, individuals that engage in treatment retain custody of their kids. They keep them in the homes. They deliver healthy babies. And then they're able to stay with them. So as negative as this crisis and epidemic is, there really is some hope and some positive direction that we're going. So I'm very hopeful for the future.
Austin, to follow up on that with the children, what does the Pensacola Police Department do to prepare in case they encounter a situation like that? You find a baby or a young child.
We have, my business is enforcement, so we don't directly deal with that, but we do have resources that we could call in. Children and families, they can be there almost immediately, especially when there's young children involved. Whenever we encounter that, and unfortunately is a lot, we do take steps to make sure they're traumatized as little as possible, because we know how shocking a situation could be like, and typically they're living in a horrible environment to begin with, so we don't want to add to any other problems in their lives.
When you are going again and looking at the civil part of this, and have a couple of minutes, I just want to briefly touch on the criminal justice system, because I know that has also been a part of your focus, because we do incarcerate. There is, again, that cost to society for doing that. But is there the treatment that needs to come with that?
So a big part of our litigation against Big Pharma is we are trying to hold them accountable for the public nuisance that they've caused in all of our communities. And what we're asking them to do and demanding that they do by way of these lawsuits is abate that nuisance. And generally speaking, we see those abatement funds going to three areas. The first being law enforcement, making sure they have the resources that they need to get through the scourge of this addiction. The second is education. I think it's vitally important that we get in the school systems and reach children at a young age, make sure that they know the dangers of the pills that are in the medicine cabinet. And then finally, addiction treatment is without a doubt the most important. I've yet to be a community where they tell me that they have open beds.
All right. And one of the things that we want to make sure we leave here with this evening is the fact that there is hope and there is help. Whether you turn to a community mental health facility, whether you turn to a faith-based organization, perhaps there are support groups out there. Know that there is help, there is hope, and we're going to explore that as well.
Jenna Bryant grew up in a military family. She was a good student and loved playing softball.
I played for the all-state team in Arkansas. I was featured in newspapers for my pitching abilities. I was normal.
She was 16 years old when she got her first prescription for Percocet after a knee injury.
And when that prescription ran out, I wanted more. And then after that, it get to the point where without the medicine, I didn't feel normal.
When she couldn't get a hold of pain pills, she tried any other drugs to help her with withdrawals. When she was 18, she married another addict.
That I wouldn't get out of bed without 6 or 7 in my system.
Her family had no clue.
Because I maintained jobs, college, multiple jobs, everything, and nobody knew. And I felt ashamed to go into anywhere and say, hey, look, I have a problem.
Brian's husband overdosed and died in 2015.
But I was so lost that I couldn't save him because I couldn't save myself at the time.
She remarried into an abusive relationship. That's when she packed her bags and kids and moved to Pensacola.
I realized that I couldn't do it anymore. I didn't want to get up and hunt anymore. I didn't want to take the money that could go to my kids.
Bryant started methadone treatment, and her life started to turn around. But she relapsed when she tried to get off methadone 2 years later.
I lost my house. I lost my kids to foster care. I went to jail.
At rock bottom, she decided to start a 12-step program with Narcotics Anonymous. But this time was different, because a friend had invited her to join Momentum Church. God was Bryant's missing piece in recovery. And now with her kids back, she just lives day by day.
We're not just a drain on society. These are people. These are moms and daughters and sons and husbands, and they're worth saving.
Worth saving. How do we save? You heard Leslie say earlier that they had done everything, time and time again. Resources certainly became an issue, and for any one of us, most likely, that would be an issue. So while help is there, how do we pay for it? How do we access it? Dustin, I want to start with you. What are the different types of treatment out there?
Sure. So I think that as the video showed, the 12-step community is a really big impact in all the communities. They typically meet breakfast, lunch, and dinner, or evening, and they're available any community in the United States. It's a wonderful place to start, but sometimes you need a little bit more, and you need the evidence-based practices. So you can start with outpatient counseling, where it's once a week or twice a week. Maybe move into intensive outpatient, where it's 12 hours a week, or move into the residential. Across that whole spectrum of treatment services, there's also medication-assisted treatment. And medications, they go in and they're often thought of as replacing one drug for another. And it's true in a sense. We are replacing heroin with methadone. We're also replacing that lifestyle. So you go from that addict lifestyle where you're stealing and lying and cheating into this recovery lifestyle. So the medication's changed, the drug's changed, but it's healthier. You're not worried about getting fentanyl mixed in. It's consistent. You're not going through withdrawal at the end of the day. And the lifestyle changes. So you move from that lifestyle that we dislike as a community. We dislike the behaviors that come with addiction. Nobody appreciates that. Nobody supports those behaviors. So if we can change those behaviors by replacing one drug with another, we do.
What about from a medical perspective, when you see patients and you suspect that something is going on? Do you try to intercede? Because I don't know necessarily that the person who is addicted realizes right off the bat that they are, or is at a position of admitting that. So where do we start the process of guiding them to the help that they need?
Right, in the acute setting, it's fairly hard to do that, because if they're in the emergency department, they're having an acute issue. It's not the time to say probably that you're taking too much. So you have to dance around that conversation and really read the patient and see if they're ready to hear that or not. So it's important that we have resources to refer them to, and we do that here in Pensacola through the Lakeview Center and several other facilities here in Pensacola. So we make sure they have those resources available to them. And it's also good to bring in to make sure they have a support system. So if they have family with them there, or someone who can be responsible for them, and we can have this discussion with the entire support group.
April?
One gentleman named Michael wants to open this up to the entire panel. He wants to know what is your philosophy on open access to Narcan?
Dustin?
I think everybody needs to have Narcan. I have it in my cabinet at home. I don't know anybody personally that has an opioid problem. I've got 4 kids under the age of 10. One of them comes home with an opiate. I want to be prepared that I can save their life. I can't treat anybody that's dead. So Narcan it's true. I mean, I can't treat anybody that's dead. So Narcan should be available readily to the public.
Well, and for those who may not be familiar with Narcan and what it is, can you describe that? What is Narcan?
So opioids sit in the brain on the receptor, and they produce dopamine, serotonin, the feel-good stuff, and essentially Narcan is the opposite of that. It's an opioid antagonist, so it goes in and binds the receptors and it pushes all the opiates out. It's very short lasting. When taken through a nasal spray or an injection, it lasts 5 to 15 minutes. So it's really imperative that you call an ambulance or EMS so that they can transport the individual. But it reverses the overdose and gives the opportunity to treat.
All right, Jeff?
Jennifer, we just saw the piece on you a few minutes ago, and you were talking about day to day. Tell me what every day is like for you. How does your day start?
It's a busy day. I have 3 kids, 5 and under. I'm a single mom. I get up and I plan my day. I focus on what to do that day, and I make sure that I put some faith and some recovery in it, whether it is just talking to my sponsor or going to church or out with friends from church or a meeting. Every day has something to do with my faith and my recovery.
It seems like the 12-step process was really key for you, and you had tried other things. Elaborate.
I really think when I went into Narcotics Anonymous, I had that terminal uniqueness. Nobody was like me. Nobody had been where I'd been. Nobody had done the things that I had done. And when I went in the rooms, I found people that were like me. I think that shaming addicts and making them feel like nobody else is as horrible as they are is a quick trip to the grave, because shame kept me from getting help for 17 years.
Why have you decided to be public?
Honestly, I lost 2 friends this past year from opiate overdoses, and they were in the rooms of recovery. And when they relapsed, they didn't tell anybody. They didn't say, hey, I messed up. I don't know where to start over again. Instead, they hid and were found dead by a child on one, and the other one was found by his mother. And I feel like if people can see that, hey, we've all been there. An addict can relate to an addict like nobody else. You feel like you've done the most horrible things that you're ashamed of, and I have. And that's okay, because that's not me now. So if someone can see that, hey, I'm not the only one that's done horrible things. I'm not the only one that stole, lied, cheated, broke laws, broke my parents' hearts. There's still help. It doesn't have to be the end. You can get past the guilt and the shame. There's others out there. There is quite a few of us, actually. They're in recovery. And you can't come to me and tell me anything horrible you've done, and I'm not going to judge you. I'm going to help you find a way past that guilt.
Do you have any advice for medical professionals or for law enforcement of how they might deal with this better?
I feel like there's a stereotype on addicts, that you see the dirty, lost everything, that you can tell an addict just by looking at them, and that's not true. I was 16, I was on track to have a softball scholarship, and I blew my knee out. My family was well known in the small town that we came from, and I could schmooze a prescription out of every doctor I saw, because they didn't think that someone who was a good student, that was a good athlete, that came from a family with 2 police officer brothers and a police officer grandfather, that I could become an addict. And I did. I'm in meetings with doctors, teachers, cops. It doesn't matter. There's no label that can say this is an addict. Let's watch them. I think the number one thing to do is just follow up. I think that's what Gigi's mom, follow up. Because after that first prescription, instead of me being reassessed, instead of having more imaging, instead of talking to maybe somebody from a recovery center to say, let's go through this and see if you're having a problem. I was just given another prescription, and I was given another one, and I was given another one. And it took 10 years of legal prescriptions before I'd gotten so far down that I was finally cut off.
Dennis, the personal stories that we've heard tonight, you know, when again, going back to Gigi's story, we're talking about young people. We're talking about individuals who started young. What is the age span? What are we looking at?
I don't think that the addiction has any age limit. The pills are readily available in homes and in our elders' homes where they can grab them without anyone knowing and start to take them that way, or taking them to school and then the schools have a problem there. So, we hear these stories, and that's what drives us, are these stories that we hear. We don't put labels on people. We're here to help. People come to my office and I hear these stories, and we do everything in our power, working again with all of our law enforcement partners to attack these avenues that we're being made aware of. But that's a big part of it, is learning where these over-prescribing doctors are believed to be, so that we can focus our efforts.
Jennifer, at what point did you know I have a real problem?
My dad was injured at work. He actually had a propane tank blow up in his face, and I stole his prescription. And that's when it hit me that I was sick.
What advice do you have for someone out there who might be watching this right now, who's right there on the verge? They are thinking, I may have a problem. I don't know what to do. I don't want to come out and tell my family. I don't want to tell my employer. I mean, it's a predicament, right?
It is, because there is a lot of, you can lose jobs, you can lose professional license, you can lose your kids. But if you think you have a problem, come to a meeting. You don't have to say anything. I came here from Arkansas, and my first night here, I went to a meeting, and I didn't have to say a word. The people made me feel so welcome and so in tune with them that I felt like I was home. If you think you have a problem, come to a meeting. Just come and sit and listen. Nobody's going to tell your name. Nobody's going to tell you were there. We take the anonymous part very seriously.
Well, it takes a lot of courage for you to do what you're doing and be public with this, so thank you, Sue.
And very definitely, thank you so much for sharing your story and reminding people that they are not alone. Dustin, when we hear these stories, for people who have not hit that bottom, for people who have not admitted to themselves yet or just aren't at that place to take that step, how do we as family members, how do we as coworkers, how do we as bosses, how do we as a good neighbor, how do we as church members, how do we know that there's someone who may be having a problem, and then from there, how do we help?
It's not easy. I'm not going to pretend, and I'm not going to tell you that it's easy. It's very difficult. It's a disease of denial. I mean, you say, I don't have this problem. I don't want this problem. This problem is somebody else's problem. So you hold them accountable. You tough love. You help them out. You make sure that they've got food and water and shelter to an extent. You don't loan them the car. You don't. Maybe you hide your purse very well, a lockbox maybe, or safe. But you give them the tools, and you say, Lakeview Center has some treatment options for you. We can have somebody come and talk to you. It could be that we're going to talk to the family practitioner. Just getting in touch with somebody and saying, I feel like my child or my loved one has a problem, and I'd really like to have somebody talk to them. Can you help? And asking for help. I think it goes a long way. People want to help. There's a lot of people in this helping field that are very motivated to resolve this and at least stamp out a little bit of the fire.
April? We got a comment from a woman from Gulf Breeze. She says both Escambia and Santa Rosa County spend a lot of time and resources on school drug education programs, for example, Red Ribbon Days, etc. Who is in charge of monitoring or critiquing whether these programs are actually working? Dennis?
Don't know that I would have the answer. I can say that I know that we've tried with our office to get into some of the school systems here to help with some of the education and providing our DEA websites that link to some of these health care programs available. And I think that's one thing that I would like to get out there. DEA.gov. There's tip lines on there. There's some other helpful information on several of the on the bottom of the web pages that you can click on that can send you to different areas for help. As far as monitoring how it's doing in the school, I don't think that I would have that answer.
Chief Robert Bage with the Fort Walton Beach Police Department. Are you guys doing anything as far as school is concerned?
Currently in Fort Walton Beach, Okaloosa County Sheriff's Office runs the SRO programs, and they're really involved in the school system. We also try as a local police department to do our part in the aspect of education and awareness and reaching out to people in the community. And I want to go back to one thing that was said in the beginning of the meeting. And you asked about law enforcement and law enforcement's role in the opioid epidemic. And unlike other agencies, and unfortunately the DA, when they said that they go after the big ones, they kind of pick and choose who they go after. As local law enforcement, we don't pick and choose who we go after. We have to help every single person that's out there. So it's from the $1 million house on the bay to the person behind this local convenience store or gas station. As local law enforcement, we don't get to pick and choose who we serve. We get to serve everybody. And we've tried our best to go out there and deal with the epidemic as best we can. And a lot of times, it's gut-wrenching for law enforcement to go out there, because we'll go out there, people will call us for a criminal issue, a trespasser, a petty theft, or something that happens. And a lot of times, we get to know the people that are there, and we start asking them, and we learn their stories. We find out why they're on the streets or how they turned out to be on the streets. And like the young lady said about people that had full softball scholarships, people that were pillars of the community at one time, and somehow became addicted to some type of drug, and now they're out there on the streets. Or they may not be out there on the streets, they may be in the shadows. They live still in a house, or they still live with a family unit, but they're suffering from addiction. And you get to hear from you asked about the family structure, or the demise of the family structure. We get to hear about that too. So you'll hear the stories where somebody will call into law enforcement and ask you to come and speak to somebody, offer them some insight or some referral. And a lot of times when we leave, we get called back again, and we get called back again. And we do the same things. We wonder, how do we break that cycle? How do we stop that endless cycle of addiction? How do we stop the cycle of where we make the small arrest, send somebody to the jail for the day, they get back out, they're back behind the convenience store, and we get to know a lot of the people that are out there, and we know them a lot on personal levels and personal stories. And we ask them, and we find out how they're doing, and we root for them. I mean, we want to see every single person kick the drug habit. But a lot of times, they end tragically. I mean, a lot of times the story doesn't end with a positive note, but every once in a while, they do end positively. And I will tell you that there are changes being made out there. The person from online asked about DARE, and they asked about Red Ribbon. Even though we may not be able to empirically measure them, every single thing we do helps the issue and helps the crisis. And we really need to look at ways that we can tackle the issue.
I'm curious to know, Fort Walton Beach, beautiful coastal community, relatively small town compared to, say, Pensacola and some other surrounding areas. Is the opioid epidemic a problem in Fort Walton Beach? And I'd be curious to know, because we have people here this evening from smaller towns, for example, Milton is represented. What are your thoughts on that? Is it?
No, we see it. We may not see it in the scale that the larger cities see, but proportionally, we probably see it just the same as they do in the larger communities. The drugs are out there. It is a regional, national epidemic. It doesn't know boundaries of the big city of Pensacola, Panama City, or other places. It stretches across the panhandle. When I came from South Florida, they asked about Narcan. We gave Narcan to our officers, hardly ever used it in South Florida. When I came up to a smaller city of Fort Walton Beach, last year they used it 35 times. I mean, Narcan became pretty much a standard thing that our officers would deploy Narcan for opiate overdoses. So you see it from the large city to the small city.
Thank you, Chief.
You're welcome.
Jeff, did you have something, Dennis?
I did. I wanted to add something. DEA, we don't pick and choose. We take those local impact cases that happen at your department, at your level, and we build on them until we can get back to where we can cut off that supply so that we can end those stories. That's what we're about, and that's what we focus on. So we don't pick and choose. We work the leads and the stuff that we get through all of our partners. That's why we have a task force. So we are out there, and we are taking these leads, and we take them seriously, and we work them back to the country where these drugs are coming from, and then we go after them in that country. That's what DEA is about, and that is our focus.
And Jeff, I know that this, again, a very big issue for you, for your firm and other firms who, again, are looking at this from a civil standpoint, that money needs to be put out there to help with treatment, additional law enforcement. All of these things, there is a cost. And the communities, the citizens, we have borne that cost. And it is your contention, as I understand it, that somebody else needs to step up and take ownership of that money.
There's no doubt about it. When you look at the root cause of this problem, as I said at the top of our time here, this crisis is a man-made crisis. And it originated with Big Pharma pushing these pills on the doctor and patient community when it was not appropriate, and the distributors coupling with that. And yes, we need funds to fix it. I think the chief would agree, and I think everybody else, every other law enforcement officer I've talked to has acknowledged that this is not a problem you can arrest your way out of. It's a problem that we need to treat, and unfortunately we need funds to treat it. Treatment is not cheap. It's expensive, and it takes time.
But when those funds come and the money is appropriated, how do we make sure that the money goes where it needs to go? So it's oftentimes we'll hear about these civil cases of many different types, you know, and not just Big Pharma and this particular issue, but you'll hear about that, and the money comes, and then the money's diverted to here, to there, to there. How do we ensure that the money goes to helping to fight this epidemic? Is there a way to do that?
That's a fantastic question and a great point that's very important, and that's why a lot of our efforts have been focused on local governments. When we've gone around the country, what we have found is that the local governments are incredibly invested in their own communities, and they want to make sure that any funds that are recovered go to service the people that are suffering in their communities. You know, oftentimes this litigation gets compared to tobacco, where we saw led by the states, and there was a lot of issues with the tobacco monies not necessarily being spent on smoking prevention, but more on other items. By focusing on the local governments, we believe that the money will go to address the problems in the local communities.
All right, April? April?
But we were actually not ready at this point. I'm sorry, I don't know who gave the cue. This is the beauty of live TV, but we'll get back to you on that.
All right, no problem. I'm sorry. Go ahead, Jeff.
Okay, Sue. Kiana Delabo is with the Children and Family and Children's Services. Talk a little bit about what your agency does and how this epidemic is affecting you.
Well, we see that the epidemic is affecting our families because nationally, America receives about 47,000 overdoses each year, and this year alone, it's been about 4,200. So we see a lot of overdoses, and so it's impacting children, families, and it's really impacting the community.
What does your agency do in this situation?
So what our agency does is we contract with managing entities to provide substance abuse and mental health services. One of our local providers in the community is Lakeview, and they are able to provide substance abuse treatment as well as mental health evaluations to those who are underinsured or have no insurance.
Do you want to elaborate a little bit? You may recall a few minutes ago we were talking about the challenges that law enforcement is facing when they go into a home and there are children there. Does your agency help in those types of situations?
That's a great question to ask me because I am the behavioral health consultant for Escambia County as well as Santa Rosa, Okaloosa, and Walton County. And so what the department is doing, we're doing things differently. It's not necessarily that a mental health diagnosis makes you not able to parent or your substance misuse makes you not able to parent. Our goal is to get people connected to treatment. Our goal is to motivate people and to help them understand the need to stay on their medication if they're on medication, or stay with whatever treatment is working, whether it's NA, whether it's there at the methadone clinic, or whether it's an outpatient service. We're really looking at recovery in a different way.
What advice would you have for a parent who may see their adult child who is struggling with this, or for that matter, an adult child who may see their parents struggling? How do you get them to take that next step to start healing themselves?
That's a really challenging question because what we often find is people aren't just using just because it's what they love to do. That's really not how the nature of addiction works. A lot of times what I see is people are dealing with unresolved childhood trauma or adult trauma that they've never spoken about. And so I would suggest that people find that one adult, that one person that you trust, and just open up to that one person. And maybe that person has seen an ad or knows about a recovery group or knows that you can go to Lakeview and receive services. And maybe that is how they can get connected, because ultimately we want to see people live happy and fulfilled lives, and we want to see no one die from an overdose.
And Jeff, at this point, we're going to ask our panelists, as our time draws to a close, I want to give you about 30, 45 seconds. I know that's not a lot of time each, to tell me what you hope we take away from here tonight from your perspective.
I hope that we know that we can all there's someone that we can reach out to with these addiction problems or information that you have. There's, like I said before, we have websites that can help direct and push some of the tips and stuff to our office so that we can take a look at some of these doctor offices and the dealers, and we also take those things and we follow up with the partners in the different areas to make sure that we're investigating the leads that we get.
Jeff?
I hope that people can walk away from this knowing that addiction is a disease, and it's a blind disease. It doesn't care if you're a man or a woman, black or white, rich or poor. It impacts everybody from all walks of life. I hope that folks will take the time and the effort to do the research and see where the root of this problem is, and ask that the people who caused this problem be held accountable, and that the funds that can be recovered be used on a local level to improve our community.
All right, Doctor.
I would just say that I'm glad we talked a lot about the stigma around being an addict, and I hope that is something that we can talk about openly from now on, and realize that if you come to a healthcare provider, we don't see you as some, that you have a moral failure in your life because you're here. We understand that we got here by a lot of multifocal process to get here. There are a lot of people that are responsible for this, and we're ready to take ownership. And I think things are getting better. I think we've seen, like we mentioned here, that the amount of prescription drugs are going down. I think having open forums like this and being able to talk about it, things are getting better. I think it's a bright future.
Dustin?
I think the thing that I want everybody to take away is that this isn't my problem, and it's not Dr. Glisson's problem. It's all of our problems. There's 5 of us at this table. There's law enforcement. There's 50 people in the audience. This is impacting a lot of people, and we're all responsible for where we go from here. This isn't something that Lakeview is going to solve. It's not something law enforcement is going to solve. We all have to work together, and that's the only way that this is ever going to improve.
And again, I want to take this opportunity to thank our panelists. We have Dennis Dawson, resident agent in charge of the Pensacola Office of the Drug Enforcement Administration, and Jeff Gaddy. He's an attorney with the Levin Papantonio firm and a former Assistant State Attorney. Thank you very much for being with us. Dr. Paul Glisson. He is the Vice President and Medical Affairs Director for Baptist Healthcare, emergency room physician. And of course, we just heard from Dustin Perry, licensed clinical social worker and Director of Medication-Assisted Treatment Services of Lakeview Center. And again, as many of them have said, we hope that you leave here tonight with the thoughts that they have left with you. But know that we appreciate the fact that you have tuned in tonight, that you have joined us via social media, that you have been a part of this audience tonight, because that shows a level of interest in this community and throughout our area. And that is critically important. But know that we leave here tonight with hope and knowing that there is help. There is help. We have to reach out. Town Hall, Addicted Florida, perhaps our next conversation, addiction gone.